like to share with you my first experience with Acriva Trinova. When we are thinking about new development related with intraocular lenses, we are thinking about the possibility to obtain emetropia, and for that it's necessary for the lens to be implantable through small incisions, but we are thinking also about the refractive predictability and refractive stability. And obviously, when we are thinking about presbyopia correction, we are thinking about the possibility to work to different distances, including reading distances. Different categories for intraocular lenses, but thinking about function, we have to explain the minimum visual acuity required for different activities. For example, for driving, we need at least 0.3 logmar visual acuity, for reading at least 0.4 logmar, and for reading speed, 0.2 logmar. These activities, or to obtain these visual acuities, we need smaller refractive defects, residual defects. And we are making, or we are taking decisions related with the implantation of bifocal or trifocal intraocular lenses. I think that I have in my mind the possibility to correct the residual refractive defects and the dysphotography phenomena refer for the patients. In this way, Acriva Trinova supposes a new development related with trifocality. It's a sinusoidal trifocal intraocular lens without steps because it has 12 continuous curves. It's a sinusoidal trifocal design. The theoretical benefits for this platform supposes that the loss of effective light is lower than with other trifocal intraocular lenses, offer us also greater depth of focus, excellent MTF results, and promises also good behavior in mesopic conditions. The addition for different distances, the intraocular lens is designed for 80 centimeters and for 38 centimeters, and the different additions are included in this slide. We have included 17 patients, 34 eyes, with a patient age between 55 and 76 years old, 7 male and 10 females. The preparative evaluation of the patient included normal criteria without extreme values related with axial length or keratometries. The technique that we have used in this study includes the use of femtosecond laser, the use also of the CTR, but is not necessary for this design, and the possibility to perform capsuloresist a little bit bigger than the capsuloresist that we use with other platforms, in the range between 5.5 and 6 millimeters is the diameter that we recommend. In this study, we have included all the patients with 5.5 millimeters obtained with the femtosecond laser. The platform is easily implanted, and we prefer the vertical position, but I think that it doesn't matter to implant the intraocular lens in other position around the capsular bag. Then, after the aspiration of the viscoelastic, the intraocular lens is perfectly placed in the capsular bag. The objective of my presentation are three, and the first one, it was to evaluate the efficiency of this platform in the real practice. In order to evaluate the efficiency, we have evaluated the uncorrected distant visual acuity, the uncorrected intermediate visual acuity to 80 60 centimeters, and the uncorrected near visual acuity to 40 millimeters. And obviously, with the best distance corrected, with the distance best correction to the same distances that I have mentioned before. Related with the uncorrected distance visual acuity, the results are good. Also the distance corrected visual acuity, but we can see in this graph the stability along 6 months period. For intermediate to 80 centimeters, the situation is the same. The same happens to 60, and the same happens to 40 centimeters. The stability of the refraction is good enough. In this graph, you have the possibility to see the different distances for the intraocular lens. Related with the predictability, and I think that could be a main issue related with the implementation of these new designs in order to avoid the enhancement for small refractive defects, as happened with other trifocal intraocular lenses. We have studied the predictability that offers this lens with a constant that suggests the company. We have included 7 days after the surgery. 95% of our cases were between plus and minus 0.50 diopters. And after 6 months period, 87.5%. The predictability is excellent from our point of view. And the stability of the refraction with 2 outsiders is also the same. The stability is excellent. Related with the refractive tolerance, I want to show this slide. This slide is one slide that contains the information related with some patients. This one, with one refractive refraction of minus 0.50 and one astigmatism of minus 0.50, had one excellent visual acuity for far distance. And in those cases, with a small astigmatism in the range between plus and minus 0.75, the visual acuity without correction was excellent. Obviously, with the corrected distance, visual acuity was better. But as you can see in this slide, the majority of them obtained good visual acuities with independence of the refractive residual defects. If we analyze the monocular, the focus curve, we can observe that it's different, the focus curve that we obtain with other platforms. With other platforms, we have a valley between the different focus of the intraocular lens. In this case, you can see that the curve is continuous between different distances. If we analyze the visual acuity that we have in the range between 0.5 and minus 0.5, all of them are included in the range of visual acuity between 0 logmar and 0.1 logmar. Thinking that for driving we will need better visual acuity than 0.3 logmar, you can see that all of them are included in this range. The visual acuity for far distances are excellent. The same for intermediate distances. If we analyze the situation in 66 centimeters with the focus curve, all of them are included in the capability to practice our activities related with intermediate vision, as the use of tablet or cooking or that kind of activities. And thinking about the possibility to read without glasses, all of them are also included in the range over 0.4 logmar. Contrast sensitivity in photopic and mesopic condition is also good enough. Speaking about halos, and glare, you know that the valley between different focus establish the entity of the halos and glare. With this curve, with this continuous curve, the presence of halos is diminished considerably. For example, if we don't ask to our patient actively about halos, they don't inform us about the presence of halos. If we ask them about the presence of halos, some of them speak about that, but as a minor disadvantages related with this intraocular lens. I think that I have, with the information that I have presented, the clinical benefits supposes an excellent compensation of residual refractive errors and fewer dysptosias, probably due to scattering reduction that offer this technology. In conclusion, excellent far and intermediate vision, functional near vision, continuous vision pattern, tolerance to residual refractive defects, and few dysphotopic phenomena. I think that this could be an excellent platform for the doctor who is thinking about the possibility to be introduced in the world of multifocality, because it's possible to obtain good results with independence of the residual refractive defects. Thank you so much.